Welcome to the Michigan Mental Health Innovation Network for Clinical Design, more commonly referred to as MyMind. My name is Sarah Moore, the Senior QI Lead for MyMind, and I am joined here with my fellow presenter, Jeff Warchall, the Senior Analyst for the program. In this orientation, we are going to cover an overview of MyMind's Collaborative Quality Initiative. Here's just a reminder that support for MyMind is provided by Blue Cross Blue Shield of Michigan as part of the BCBSM Value Partnerships program. Although BCBSM and MyMind work collaboratively, the opinions, beliefs, and viewpoints expressed in the training do not necessarily reflect the opinions, beliefs, and viewpoints of Blue Cross Blue Shield of Michigan or any of its employees. In today's orientation, you will meet the Coordinating Center, cover an overview of the Collaborative Quality Initiatives, or CQIs, review the goals of the MyMind CQI and its first initiative, Zero Suicide, and receive information about where you can access information about the CQI resources for implementation and MyMind Partner Portal information as well. First, let's meet the leadership team. The MyMind CQI is co-directed by Dr. Brian Amadani and Dr. Kathy Frank. In the early 2000s, Kathy and Brian implemented the Perfect Depression program at Henry Ford Health, which led to international interest and commitment to eliminating suicide through Zero Suicide Initiative. Dr. Frank is the principal author of suicide prevention guidelines that were central to earning the Codman Award, the Joint Commission's highest honor, and the American Psychiatric Association's Gold Award in 2006. Brian is the Henry Ford Health PI for several NIMH and NIH studies that have led to several key research findings related to healthcare access patterns before suicide and evaluation of zero suicide model as the gold standard for evidence-based prevention. Heather Amdahl is the program manager for MyMind, who brings her experience in behavioral health integration and quality improvement programs to lead operations for the MyMind CQI. Next, we will introduce you to the rest of the team. Myself, Sarah Moore, as the Senior Quality Improvement Lead. I also am a licensed social worker. My background includes suicide prevention, crisis intervention, and individual and group therapy. In my role as the trainer with MyMind, I will lead, facilitate, and coordinate the design and implementation of behavioral health quality initiatives. Jeff Warchall is a senior analyst with the experience in technical and market-facing data analysis. Within the MyMind CQI, he manages the partner portal, which allows collaborative participants to access trainings, view program resources, examine reports, and interface with the Coordinating Center team. Jeff also supports our data dashboard, which is still in the works, and we are excited to roll out that over the next training year. There are two QI leads, Leslie Johnson and Olga Gagnon, who also create and provide training for participants. Gabrielle and Shwahan support the data team, and we also have our senior marketing specialist and content experts that support the CQI. Now that you have met the team at the Coordinating Center, we would like to introduce you to the purpose of the CQIs. Collaborative Quality Initiatives, or CQIs, are part of the Blue Cross Blue Shield of Michigan Value Partnerships program. They focus on improving common and costly surgical and medical care areas. The CQI model has three key components: data registry, initiatives, and champions. As part of the CQI, participating providers collect, share, and analyze data using clinical registries. This data-driven approach helps implement changes that enhance patient outcomes in complex care areas. CQI registries enable a more detailed analysis of how processes affect outcomes compared to looking at individual groups or hospitals. Each CQI creates initiatives based on data from evidence-based treatment practices. These initiatives aim to use data to set care standards and reduce costs. At each practice, a practice clinical champion is chosen to engage participants, share CQI insights, and guide the implementation of initiatives in practice. The goal of each CQI is to foster collaboration across healthcare by engaging practitioners to discuss findings, exchange best practices, and learn from high performers. This framework is intended to create a collegial environment where providers can learn from one another, provide performance feedback, and openly share their experiences. At present, the BCBSM Value Partnerships currently administers over 20 CQIs in various areas of care. From this group, there are 4 population health CQIs that focus on taking preventative approaches to improving healthcare outcomes by fostering collaboration within primary care and specialty care. MyMind is one of these physician organization-based CQIs. Now, let's move to specifics of the MyMind Collaborative. MyMind aims to bring to the forefront the morbidity and mortality of mental illness in the state of Michigan and provide solutions. The CQI will begin with its first initiative, Zero Suicide, which will focus on reducing suicide deaths and attempts within the state. So how do we intend to reduce suicide? Zero Suicide is a healthcare-driven framework aimed at preventing all suicide deaths among individuals receiving care. It emphasizes that suicide is preventable by applying evidence-based interventions and quality improvement methods. Developed in response to a call to action by the U.S. Surgeon General and National Action Alliance for Suicide Prevention, Zero Suicide provides a structured care pathway for suicide prevention across healthcare systems. The model was inspired by Henry Ford Health's belief that deaths by suicide are preventable, leading to the development of a framework with evidence-based interventions tailored to each stage of a patient's care. This framework standardizes interventions within a suicide prevention care pathway, allowing each clinic to adapt it to its specific needs and create a formal suicide prevention protocol. As part of implementing the Zero Suicide model, providers learn to leverage behavioral health resources, such as the collaborative care model, and brief interventions to identify and modify suicide risk in the appropriate setting. This comprehensive approach integrates behavioral health into general health care to enhance the overall effectiveness of suicide prevention efforts. The model's name, Zero Suicide, underscores its commitment to reframing how we approach patients at risk. Our director, Dr. Frank, teaches us to imagine that the patient is a family member or a spouse, and asking ourselves whether we would want to do everything possible or want our healthcare providers to do everything possible to prevent suicide. If a simple intervention or brief conversation could save a life, the only acceptable goal is zero suicides. The initiative extends beyond just the participants in MyMind. It calls on us all to contribute to the societal change needed within healthcare and beyond to reduce and ultimately stop deaths by suicide. On this slide, we highlight the strides made to achieve our current state with the MyMind Zero Suicide Initiative. In 2001, a team from Henry Ford Behavioral Health Services started the Perfect Depression Care Program with the bold goal of getting to zero suicides. Through the 2000s, the research evolved to incorporate suicide prevention strategies into every level of the health system and led to a reduction in suicide rates at Henry Ford Health. Research eventually expanded to include healthcare systems outside of Michigan. In 2011, the National Action Alliance was formed to create a national strategy to reduce the number of suicides to zero, and this was later adopted by SAMHSA and the Suicide Prevention Resource Center, or SPRC. With the research to back the numbers, the Zero Suicide Initiative became the first program in the U.S. that was linked to decreases in suicides among behavioral health patients. This launched the zero suicide movement. Over the last 20 years, the adoption of zero suicide model has led to success in Michigan, nationally, and even internationally in over 20 countries. As part of the team that started the Perfect Depression Care program at Henry Ford and the pioneers of My Mind, Dr. Amadani and Dr. Frank recognize that we have a long way to go to increase community access to zero suicide interventions. A demand for zero suicide strategies locally fueled Dr. Amadani and Dr. Frank to apply for the CQI program through Blue Cross Blue Shield of Michigan in the Value Partnerships program. The My Mind Collaborative is the first statewide quality improvement initiative with the ambitious goal of putting mental health care on par with physical health, connecting mind and body. This slide shows that by focusing on suicide assessment and adopting suicide prevention measures throughout the healthcare system, Henry Ford Health saw a dramatic decrease in suicide rates with zero suicides in the health system in the year 2009. Henry Ford Health has been able to maintain the reduction in suicide rates since 2001 and continues to work toward the goal of zero suicides, which is why Henry Ford is also a participant in the My Mind CQI. My Mind co-directors recently published a paper with findings that support zero suicide as an effective and scalable model for suicide prevention in outpatient care. You can check this article out in the Journal of the American Medical Association, or JAMA. Another recent article involving My Mind co-director Dr. Amadani was published in the Annals of Internal Medicine and showed a 25% reduction in suicide attempts in the 90 days following a primary care visit. Again, this shows that following the zero suicide model prevents suicide and saves lives. And here we just want to add in a note about language. In the suicide prevention community, we use the phrase die by suicide instead of committed suicide to show respect for those affected by suicide. This shift in language reflects a compassionate understanding of the issue, similar to how we talk about other illnesses. Historically, the term commit was associated with viewing suicide as a crime or sin. Today, we aim to treat individuals with suicidal thoughts and behaviors with empathy rather than judgment. Additionally, we avoid terms like successful or unsuccessful when we refer to suicide attempts. Instead, we emphasize using plain language like died by suicide. We also refrain from labeling suicide attempts as a cry for help or manipulative actions, as this can further stigmatize mental health issues. So how do we intend to reduce suicide? By creating a two-pronged strategy that relies on the partnership between primary care and behavioral health, we develop a collaborative clinical model. Training primary care in suicide prevention is critical to reduce suicide deaths and attempts. Research indicates that 83% of individuals who die by suicide and greater than 92% of those who attempt have had a healthcare visit within months of the attempt, and many of those visits are not in behavioral health services. Only 33% of those who die by suicide have ever had a behavioral health visit, which highlights the importance of detection in other settings where people are more likely receiving care. As mentioned previously, it was found in a NIH longitudinal research study that nearly all individuals who die by suicide received healthcare in the months prior to their death. The most common visit types for these individuals were medical specialty and primary care visits without a mental health diagnosis. These findings present an immense opportunity for suicide prevention to take place in primary care and medical settings, where patients are most likely to receive care prior to an attempt. Targeting efforts to improve identification of mental illness and suicidal ideation will prevent a large proportion from remaining undiagnosed and undetected prior to death. So thinking about designing for zero as a necessary standard. As Michigan residents, we're familiar with the Motor City and their focus on zero defects in automotive, aviation, and nuclear power industries. Imagine the safety risks if these industries didn't prioritize zero defects. Would we feel safe buying a car or getting an airplane ticket and flying, or even living near nuclear plants, which some of us do? If these industries strive for zero, why shouldn't healthcare? At my mind, we believe zero suicides is achievable, even if it seems challenging. We know it takes effort, but with your help, we can get the ball rolling towards the critical goal of zero suicides. Health systems, governments, and communities must collaborate to reduce stigma and improve access to resources and care for individuals who are in crisis. A system approach is essential to effectively prevent suicide. The core values of the zero suicide model are leadership and cultural transformation. We know leaders must drive suicide prevention within health systems and society. Implementing safety protocols is a crucial first step. Timely access to care. Meeting patients' needs during a crisis is vital. We know that you might not always be able to get a patient in for behavioral health treatment, so we'll provide tools to support patients with suicidal ideation in real time and strengthen care pathways for referrals. Alliance with patients. Building trust through active listening and showing care can foster safety and collaboration between patients and clinical teams. So we know that that alliance is crucial. And thinking about continuity of care and shared responsibility. Suicide prevention should involve all providers, not just behavioral health. Effective communication and warm handoffs are key to shared service responsibility. And lastly, thinking about performance evaluation and improvement. Regular evaluation and data analysis are necessary to enhance suicide prevention efforts and achieve the goal of zero. So those are the core values of the My Mind CQI. So how does My Mind intend to implement the Zero Suicide Initiative? Our initiative aims to prevent and reduce errors using quality improvement techniques and evidence-based practices. To do so, we want to be clear about the asks for primary care and specialty care. Our recommendations for primary care are that they screen for suicide risk at every visit using the PHQ-9, assess for imminent risk, and provide a warm handoff to a behavioral health provider for a risk assessment. Our CQI does offer resources and training on brief interventions to help when behavioral health is not easily accessible for the patient. And the ask for behavioral health is that they partner with primary care to provide and complete risk assessments at every visit and initiate treatment to reduce risk after identification. So it's crucial for primary care physicians and other non-behavioral health providers to understand and incorporate zero suicide recommendations. They should be prepared to intervene with patients before they leave the office, such as providing the 988 suicide and crisis lifeline number. Collaboration among primary care and specialty providers is key for assessing and reducing suicide risk. This includes supporting the removal of lethal means and involving family members, as these actions have been shown to lower risk. My Mind helps primary care physicians feel more confident in these interventions, especially when access to behavioral health services is limited or patients decline treatment. We also create opportunities for collaboration between behavioral health and primary care to strengthen those partnerships. After screening patients with the Patient Health Questionnaire 9 or PHQ-9, providers can choose the best tools and interventions for their clinics. We'll cover implementation in future modules. So as you identify individuals at risk for suicide, consider implementing low-intensity prevention strategies in your organization. This can include screening all patients using tools like the PHQ-9 or the PHQ-2 plus item 9 of the PHQ-9 to screen for suicide risk, as well as providing crisis support hotline numbers to every patient. Also, evaluate the more intensive approaches and interventions your clinic currently has or could adopt to better support those at higher risk. Why is this important? Once participants have begun fully implementing the zero suicide model, we aim to increase the identification of suicide risk within the population and improve care coordination across primary care and behavioral health specialty care with outpatient services. The long-term outcomes of the initiative will be to reduce the number of suicide deaths and attempts and decrease the number of emergency department visits and hospitalizations related to suicide. In order to support the work of the collaborative in implementing the Zero Suicide Initiative and future mental health initiatives, the My Mind Coordinating Center will focus on 4 key objectives. 1, maintaining a coordinating center with expertise that can guide the implementation of My Mind initiatives by developing clinical tools, training, and resources that support quality improvement work. 2, we will recruit and sustain collaborative partnerships with physicians in mental health specialty care and primary care across the state who are eager to learn, receive performance feedback, and openly share their experiences. 3, we will train clinical staff to adopt core elements of the zero suicide model, such as risk identification, patient engagement, treatment, and care coordination during transitions in care. And lastly, we'll develop a registry to evaluate process measures, patient outcomes, and cost to inform clinical recommendations and drive new initiatives within the CQI. As we think about the overall goals of the My Mind CQI, it is helpful to look at the program implementation life cycle as it applies to the Zero Suicide Initiative. The first step in the My Mind continuous quality improvement process is for physician organizations leadership to commit to participating in My Mind and to recruit practices that are interested in implementing the zero suicide model. In the upcoming year, the recruited practices will advance their engagement by identifying practice clinical champions from both primary care and behavioral health specialties. These champions will take part in a train the trainer model, enabling them to promote best practices within their organizations. As the initiative progresses, and once the coordinating center has established a registry, participants will begin tracking process metrics as outlined in the data collection strategy. This will help develop a baseline of care, which is essential for evaluating effectiveness. Based on key findings and feedback from participants, the Learning Collaborative will create quality improvement activities or QI activities and set specific goals aimed at enhancing patient outcomes. Finally, the evaluation of these QI activities will inform the development of best practices for suicide prevention across behavioral health and primary care settings, driving the identification of new initiatives for the collaborative. So what data metrics do we hope to capture? The data registry table on this slide accounts for the 4 pillars of the zero suicide model. those being identification, patient engagement and care, treatment, and transitions in care. Over the course of the initiative, participants will evaluate how and where these elements are cataloged in the electronic health record, measure the number of individuals receiving these process measures, and finally assess the effectiveness of the initiative in improving suicide outcomes across the healthcare system. Now we will move on to the next portion of our presentation, which covers physician organization and practice roles and requirements in achieving the Zero Suicide Initiative. Each physician organization, or PO, will identify 3 key roles throughout the initiative. A PO representative will comprise the leadership team that oversees practice clinical champions and is the main link between the MyMind team and the practices. These representatives ensure effective communication and guide project implementation to align with organizational goals. A provider lead is a clinical leader responsible for sharing performance and quality improvement information with practice clinical champions. This lead supports training and QI projects and attends meetings with the MyMind Coordinating Center. They also help recruit practices by promoting MyMind's mission and benefits. Ideally, a PO should have both a primary care and a behavioral health lead, with the option for a secondary for support for both of those. The administrative lead manages program operations and coordinates activities with MyMind. They collaborate with other PO leads to share information and engage practice level teams. The administrative lead supports recruiting practices for MyMind and can have a secondary support person as well. And then the quality assurance lead is responsible for data oversight. This lead works with practices to ensure data meets continuous quality improvement requirements. They troubleshoot data issues and collaborate with the MyMind Coordinating Center to enhance data sharing processes. This role includes monthly meetings with the Coordinating Center and may have a secondary person for support as well. In year 1 participation, requirements can be summarized as the following. Form a PO team. Recruit outpatient primary care and behavioral health providers to participate. Submit all participation agreements. Communicate program information to practices, including the practice clinical champions and practice liaisons. Share provider and patient education resources. Participate with practice clinical champions in trainings. Provide oversight to practice level implementation of the Zero Suicide Initiative. And participate in MyMind collaborative and quarterly meetings. So that's for our PO leadership. Now we'll cover the roles needed for each practice to participate in the MyMind CQI and Zero Suicide Initiative. All right, so a practice clinical champion is an engaged leader within a participating practice who is passionate about integrating behavioral health and physical health to reduce suicide risk. Primary care champions can be a physician or advanced practice provider, or APP, in internal or family medicine. And behavioral health champions can be a psychologist, psychiatrist, licensed social worker, or counselor. Other patient-facing clinical leaders may also serve as champions with approval from the Coordinating Center. We work closely with their teams, understand clinic processes, and participate in coaching calls, trainings, and regional meetings. They share important MyMind information and guide quality improvement efforts, such as the yearly PDSA. A practice liaison is an optional role that can support the practice clinical champion. They serve as the point of contact for MyMind administrative tasks and must be actively employed in a patient-facing role. The liaison helps share MyMind updates, communicates challenges, and may attend Zero Suicide trainings or assist with QI projects. In my mind, we use the train the trainer model to support practice clinical champions and practice liaisons to give other providers at their practices education on zero suicide recommendations, including best practices for suicide prevention. We support this model by providing curriculum training with our QI lead team, including the training modules and coaching calls you attend. We provide supplementary materials and resources such as handouts on zero suicide protocols, patient and support person facing resources, as well as helpful links to broaden your education on quality improvement in different aspects of suicide prevention. We provide drop-in sessions and office hours to make ourselves available outside of the meetings for further support. And most importantly, we encourage collaboration and collaborative discussions that enhance learning and really move innovation forward. Year one requirements for practices include identifying a practice clinical champion and a practice liaison for each site, submitting all participation agreements if applicable, respond promptly to MyMind's requests and complete tasks on the MyMind partner portal, such as the annual care pathway survey, collaborate with the physician organization or PO to provide feedback on trainings, actively participate in trainings for physicians and staff and other clinicians on the clinical suicide prevention pathway, pilot the implementation of the suicide prevention care pathway by completing the Plan Do Study Act or PDSA activity, and participate in regional learning collaboratives to share best practices and discuss barriers or successes from the first year. As you and your practices navigate participating in MyMind, we rolled out some policies to help you navigate participation and coverage. These policies can be found in the MyMind handbook in our document library, and Jeff will tell you about them shortly in the partner portal presentation. All right, so practice coverage and attendance policy for MyMind. To help participants effectively implement MyMind quality improvement initiatives, a practice coverage and attendance policy has been established for selecting practice clinical champions and liaisons. Clinical role requirements. Champions or liaisons must have a clinical role and work directly with patients at their practice. Practice limitation means that each champion or liaison can oversee a maximum of 2 practices in a curriculum year. This ensures that they can attend trainings and share information effectively with their clinics. Training attendance policy says that if a champion covers 2 practices in year 1 of MyMind, they attend year 1 trainings only once, but must submit a unique PDSA and care pathway survey for each practice. So you only have to attend this training once, even if you cover 2 clinics. However, you will have to do a PDSA and a survey for each practice that you are supporting. And then as folks transition in and out of roles, as they do, if a champion or liaison leaves during the training year, a new appointee can take over with the approval from PO leadership. PO leadership should prepare the new appointee and inform the MyMind QI lead team and training team. This includes scheduling a virtual meeting for new champions to get familiar with MyMind and ask questions. We have established an attendance policy to clarify expectations for participation in meetings organized by Blue Cross and MyMind. So for in-person meetings, participants should sign in, stay attentive, and engage in discussions by sharing insights or asking questions. For virtual synchronous meetings, participants are expected to attend the entire session with their camera on as much as possible. They should also participate in discussions using either the microphone or chat function. We recognize the value of real-time discussions, and we want participants to be able to use this time to collaborate. Although we cannot offer CMEs or CEUs for this module, there will be opportunities to receive CME and CEU credit in future synchronous modules. For the asynchronous format, those unable to attend the synchronous trainings, there will be an asynchronous option that will be available for most training modules. Attendance will be recorded based on the completion and submission of required materials, such as watching videos and taking quizzes through the MyMind Partner portal with a passing score by the due date. So we are providing asynchronous trainings for most of the trainings in MyMind. For any ones that aren't available, we will let you know. Here we have a layout of what the training schedule will look like over the measurement period. Year 1 will have 4 hours of training total. Today's training in Module 1, we are helping you to get familiar with the CQI and our first initiative, Zero Suicide. In Module 2, we will start to discuss further the recommendations that MyMind provides related to screening, assessment, and interventions that are evidence-based to support suicide prevention. Although we are talking about the care pathway throughout the second module, Module 3 will really drive home the big picture of what we are striving for, which is a care pathway that patients can follow throughout their journey during the primary care and behavioral health appointments, as well as during transitions in care that focuses on patient safety and suicide prevention. In Module 3, we will also provide participants with education on the Plan, Do, Study, Act, or PDSA cycle to support your first quality improvement assignment for MyMind. You will see a note on the bottom of the right corner of the screen as a reminder that the Care Pathway Survey is due December 1st, 2025, which you will be able to log on to the portal today after your training to complete. So please get that one ticked off of your list today along with your Module 1 training. Jeff will be showing you how you can do that shortly. As a note, practice level participants, so a practice champion or a practice liaison, from each practice must complete all 4 hours of training to move forward into year 2 of MyMind. We will be providing asynchronous options for those of you that would like to go at your own pace, but having the ability to ask questions, network with your peers, and possibly get some CMEs or CEU credits for the virtual synchronous options is a nice bonus for attending in real time. PO leadership is always welcome to attend these trainings as well, and we love to have leadership in the room to get their perspective and give them a chance to hear from the providers at times. Again, all of these tasks culminate in your first PDSA due on May 1st, 2026. Around that time, in May and June, we will also be hosting our regional meetings, which we ask that a champion or liaison from each practice attend one regional meeting during the measurement period. And now we're going to cover the MyMind Partner Portal, and I will pass it off to Jeff.
Thank you, Sarah. This is Jeff Warshaw. As Sarah mentioned, I am the senior analyst for the MyMind project, and I also manage the Partner Portal. And I'm going to give you a brief introduction to the Partner Portal today. I'm sure you've all already been on there a little bit to schedule this training, but I'm going to go through some of the other functionality that the portal provides and teach you how to complete your care pathway survey and also do your PDSAs later in the year. So the portal is divided into two primary sections. One is for practice champions and one is for PO leadership. In this training, we're only going to cover the practice champion section of the portal. But before we do that, we're going to look at a couple of the supplemental sections of the portal, namely the document library and the helpful links. When you click on the document library, you come to this screen, which has all the documents that we have uploaded for you to download and use at your clinics. The portions that are highlighted in red are different places to look through these documents. You can type in a keyword in the search bar, the document library by that search term, or if you're, say, looking up a specific topic like PHQ-9s, you can use the caret outlined on the next to where it says all documents and search for specific categories of documents that way. The helpful links button brings you to a page where you see some links to some websites that our QI team thought would be helpful, and each of these links will go to navigate right to that website. We will continue to add sections to this as we come across more helpful links, and this is always under development. So now we're going to actually look at the Practice Champion dashboard itself. When you click on the Practice Champion dashboard button, the first thing that you'll see at the top of the page is this list of all of the providers that are participating in My Mind for any clinic for which you are either the Practice Champion or the Practice Liaison. So as Sarah covered earlier, this is fundamentally a train-the-trainer model. So you are the trainers, and these are all of the people that you will train after you go through the various trainings in the years to come. Below that, you will see perhaps the most important aspect of the dashboard, which is the training status report. This shows you all of the trainings that you're responsible for completing in the current participation year. You can click on the schedule a training to schedule a session like or a live virtual training, or if you can't make one of those, there are asynchronous options for most of the trainings in the various years. If you click on the asynchronous training button, it'll navigate to this page, and it will give you a list of all of the trainings that are available this year to complete asynchronously. When you click on one of those, it'll bring you to a page that looks like this, where you'll get to watch a video of a recording of one of the training sessions. And once you have completed it, you can click on the Take the Exam button on the bottom. That will bring you to a page that looks like this, where you'll be asked 10 random questions from a question bank. A score of 8 out of 10 is considered a passing score, and you can retake the exams any number of times in a given participation year. Back to the Practice Champion dashboard, in addition to the training status report, there is a task assignment report in the lower right-hand section outlined in red here. This shows you some additional tasks that you must complete in a year in addition to the trainings that you must attend. So, for example, we have the Care Pathway Survey and the PDSA. To complete the Care Pathway Survey, you can click on the task itself, the button that says complete this item, and it will bring you to a page that looks like this. Here you must first provide the practice name of the survey that you are completing at this time. Reminder, you have to complete one survey for each practice for which you're responsible for. Once you've selected that, the portal will determine if that is a primary care or behavioral health practice, and then populate the form with the questions appropriately. In addition to the Care Pathway surveys, there is the PDSA that you're assigned each year. This will be covered in more detail in future modules as to what you need to actually do on the PDSA, but I'd like to cover how you access the PDSA manager in this module right now. So to access the PDSA manager, you can either click on the button that says go to PDSA manager, or you can click on the link that says complete this item next to the PDSA assignment, similar to the Care Pathway survey. When you click on either of those buttons, you will come to the PDSA manager. On this form, you'll see all of the PDSAs that you have ever completed. The first time you come here, it will probably be empty, unless a different person at your practice has completed a PDSA before you get there. To start a new PDSA, you'll click on the button at the bottom of the screen that says Create New Lineage. This will create an empty PDSA at the top of the list, or it will be the only item on the list if your list is currently empty. Once you've done that, you click on that record, and then that opens up the detail view, which will be empty, mostly at the beginning because you haven't entered any details yet. And you can click on the Edit button from the detail view. When you do that, your PDSA Manager main screen, where it had previously listed all the PDSAs, will now be the PDSA form itself, which asks you a series of questions, and you can proceed through those at your own pace. You can save it at any time. It will remain in the list, and you can return later to finish it if you have come up with more ideas, or if you have to revisit it because you've tested something in your clinic and need to change information on the PDSA. The last thing I'd like to cover on the portal is the Contact Us button. This is on the landing page, the first screen you see in the upper right-hand corner. When you click on that button, a little pop-up will show up, and you can ask us any kind of question, any sort of technical question you have about the portal, or really any question you have about the program altogether. That comes to a group email address that is monitored by all of us, and the appropriate person will answer your question within 24 hours. So the next steps for all of you to complete is, first of all, to complete the annual care pathway survey. It is available on the portal right now, and you can do it as soon as this meeting is over. On your own time, please review the document library and the helpful links websites. And then lastly, if you have not yet done so, schedule your training for Module 2 on the portal.
All right, thank you, Jeff. So just to wrap us up, we have some key takeaways here. The goal of the MyMind CQI is to create a collegial environment so practitioners gain trust to be able to share their experiences, best practices, and work toward the common goal of zero suicide. Build your quality team. We want everyone to be involved in suicide prevention, but we know some staff will be more passionate than others. Ask them to attend upcoming MyMind trainings and join the QI team. And lastly, the annual Care Pathway Survey and upcoming MyMind trainings will help you to start thinking through current pathways and practices and key staff that help prevent suicide at your organization to consider for upcoming quality improvement cycles. We have some resources here for participants. There's a QR code for our website, as well as a QR code for the MyMind Partner Portal, so you can get there quickly if you need to. We always try to provide references and answer questions. You can email us directly at mymind@hfhs.org or use that contact us on the portal. Either way, we will get it and we will get back to you as soon as we can. We also wanted to say here that we understand that as providers, you also might be struggling. So we want to support that you reach out and use 988, call or text or chat with them online if you need to. We always want you to take care of yourself first so that you can then take care of your community. As always, we're interested in feedback. We're always trying to improve as a quality improvement initiative. So let us know if you have any feedback, and we will be happy to consider that as we continue to evolve our trainings and our CQI. Thank you for attending this training today, and I hope you have a great rest of your day.